a ridiculous increase. It is dwarfed only seemingly by our inflation rates these days, but you know, through the extra ambulances we're able to put on the streets, we've been able to respond to those calls pretty effectively. Because we are owned by the cities we serve, throughout this presentation, you'll see a few things that we try to use to give you some transparency into what we do. This EMS survey team report card is one of those things. We hire third-party agencies basically to come in and do evaluations in different aspects of what we do to give the member cities some input into how we're performing and whatnot. The survey team there, Prescani is an organization that does hospital surveys, and survey team is affiliated with them. There you see our overall scores is 92.71, which exceeds the national average. And they grade on everything from the initial 911 call all the way through the billing process. And to have a score out of 100 points that's that high when people are getting an ambulance bill that's like $2,000 is pretty impressive. So, but you know, we continue to work through that. The next slide there, that's just a picture of, you know, I mentioned over the years through COVID-19 challenges that we faced. Basically, everybody's familiar with the challenges that New York experienced. And we were prepared to go with that. We met with our first responder agencies and we said, okay, basically as sad as it can be, we kind of have to lay out stages if it gets to that New York stage, how to triage patients and whatnot. And we actually implemented this card at a very high level to try to keep the call volume off of the hospital so that it didn't get overrun with patients that didn't necessarily need to be there and the beds could be saved for more acute patients.
That's the end of the presentation.
Yeah, I thought you was going to be quick. And so one of those things is people would test positive for COVID and they call 911. And we go and evaluate them, and everybody knows it ran the gamut from, unfortunately, a lot of people died from it. Some people just kind of had a flu. Some people didn't even feel anything. And so we would assess these patients. Our medical director wrote protocols that allowed us to leave the patients there on scene, and we helped direct them to more appropriate care through their primary care physician, or the hospital systems had COVID hotlines set up where they could get appropriate treatment rather than going into the emergency room, taking an emergency room bed, and all that kind of stuff. On the back end of that, those surveys that I showed you earlier were very positive. People really appreciated having the opportunity to stay at home and be treated at home and have more appropriate care, because hospitals were not allowing visitors and that kind of stuff, which, you know, as you get, well, even being younger, but especially as you get older, you know, it's scary to go in the hospital by yourself with a disease that a lot of people don't know very much about. So, again, we have really positive feedback with that. A lot of our COVID-19 activities throughout the pandemic involved the little guys in the alien suits there. We're doing COVID testing out front of our building every morning with Tarrant County Public Health. We have a really good partnership with them. And they would call in the folks that were going to be tested the next day. We would swab them while they sat in their car and send their tests off to Tarrant County Public Health Lab, and then Tarrant County Public Health would follow up with their test results. And we did that every day for probably 18 months or so. We also provided monoclonal antibody infusions for our first responders that contracted COVID and were eligible for it, as well as picking up some hospital overflow when the hospitals were over capacity and they didn't have room for people, because you had a 10-day window that you could get those treatments. And then we also, of course, provided vaccine clinics. We did mobile clinics throughout the communities and whatnot. So our average response times throughout the process was, we experienced a lot in the last couple of years with, like I said, with COVID starting. We actually slowed our call-taking process down to make sure that we could effectively screen those patients and kind of give a little bit of a red flag for the first responders, so they didn't go into the house without the appropriate PPE. We did see an uptick in response times, as I mentioned, some of the challenges with just, you know, I think over 30% of our staff ended up contracting COVID at some point during the last few months. And but again, through the work with our first responder groups and some of the things that we've been able to do, we've pulled down response times here in the last few months, and they've continued to decrease, which is what we want to see.
So you're going and visiting COVID patients,
Yes.
and yet only 30% of your staff got COVID. That's pretty impressive.
It was 30 to 40%, something like that.
That's really impressive.
So we put a lot of time, effort, and energy into finding masks and appropriate PPE and that kind of stuff. So I was not so lucky. I tried it twice. My clothes looked like so much fun. I was like, hey, I got to try that. but my 6-year-old gave it to me. As 3/4 of her kindergarten class got it. So. But one of the other big things is financial efficiency. We participate in a state and federal program that offers some Medicaid funding to make up, every time we run a Medicaid patient, basically we lose money on that patient. And this funding helps make up some of that difference. Part of it is we have to participate in a third-party cost reporting study, and for the last over 7 years, we've been the lowest cost municipal provider in the state of Texas. As far as that goes. So we work very hard to maintain efficiency for you all. We operate the ambulance service on no tax subsidy currently, and we continue to strive to do that. So here we go. A couple other things: the dual accreditations through the Commission on Accreditation of Ambulance Services is known as the gold standard accreditation in EMS. We have been CAS accredited for multiple years. We just recertified through that process the last year. Again, a third-party agency comes in. They go through the building, actually provide, they look at all the policies, and then they randomly grab our employees and ask them questions about what to do in certain scenarios, so that I can't just go Google good EMS policies and print them out and give them to the guys. Our folks actually have to know what they are, and we have to show that we've been following those. So we got that in the International Academies of Emergency Dispatch. We've been accredited with that for over a decade. That's our 911 call center. Basically, if you've ever called 911, you get asked a billion questions, and you're like, just please send an ambulance. We are sending an ambulance while they're asking the questions, but it helps triage the acuity of your call, so that somebody that is not breathing, if you've got a stubbed toe, we're sending the ambulance first to the one that's not breathing, and then maybe sending one that's a little bit further away to the stubbed toe. And we have a QA process that's associated with that, and that's what they check on. Some of our challenges is, as costs have gone up everywhere, the insurance payments have continued to decrease over time, and so we continue to struggle with that. Basically, that is where the revenue for the ambulance service comes through, are the billed fees through insurance, and we continue working with the state legislature and the insurance companies and whatnot to address that. We went in network with Cigna this year with a different program that I'll mention here in a little bit. And so we continue working through that, because that's a big challenge. And then, of course, the patient payments, those have also decreased over time as folks, as they look at new financial challenges. And we have a lot of different programs that we offer to people that end up being responsible for a patient invoice. One of those, we revamped our charity care policy. So if you don't have insurance and you make 4 times the federal poverty level, which for a family of 4 is over $100,000 a year, we will write off your entire ambulance bill. There's another program that's out there with the state that will provide some funding for that. So that's why you see the large increase. And last year we wrote off just under $26 million in charges for patients under that program. If they don't qualify for that, we also have payment programs that we work through, and of course, if somebody just wants to pay cash, we'll take that also. So, one of the big things I was talking about earlier with our additional ambulance unit hours is the tiered ambulance deployment. And what that looks like, historically, we've always had a paramedic and the EMT on an ambulance, and a paramedic's often described as a cardiac tech, and that they go through additional education for learning EKG rhythms and medications and things like that. Believe it or not, people actually do call us for stubbed toes, and people do call us for leg pain they've had for 3 weeks and things like that. And those folks don't necessarily need a cardiac tech. So what we've been able to do is put 2 EMTs on those ambulances. EMTs, we have a little bit better luck getting more of the EMTs, and they're a little bit lower cost. And so, we were able to add some additional ambulance hours and better match the patient's complaint with the level of service that